Thank you, Mark, for this kind introduction, and thank you for the invitation. And of course, some of you I know personally, and I know what all kind of difficult situations there are with children who have neuroblastoma, and especially if they get a relapse. And we have to say that relapse is still a major problem of neuroblastoma treatment. Even the frontline therapy gets better. And we focus in our hospital on patients, especially for refractory or relapsed neuroblastoma, because we think what we can improve here in relapsed neuroblastoma will automatically improve also frontline therapy. If you find ways to improve relapse outcome, you will have an impact on the frontline therapy as well. And the German data in our German multi-center trial of relapse are not very promising, but I think we have to face the reality. Maybe it's getting a little bit better, but if the relapse is in our study NB97 with long-term follow-up published by Barbara Hero, we see that if the relapse is less than 18 months after end of the therapy, the outcome is poor. If it's a late relapse, some patients have relapses after 5, 6, 7 years. Our longest relapse was 20 years after a patient had neuroblastoma. The outcome is a little bit better, but still not what we can be happy about this kind of outcome. So we are looking into other ways of therapy of this relapsed neuroblastoma, and practically all of these patients have already received the autologous transplantation, because this is a frontline standard therapy nowadays for most of the patients. So we thought it makes no sense to do the same again and do another autologous transplant in the relapse phase. So we look more and more into the allogeneic transplantation for neuroblastoma, and this is different than from autologous, because you take the bone marrow or peripheral stem cells from a healthy donor, so you don't have to worry about contaminating neuroblastoma cells in the blood, as we sometimes might do, and give this to the neuroblastoma patients, but not only in the hope that with the chemotherapy, what you do, you eliminate residual neuroblastoma cells, but this is more kind of gene therapy, because you transfer the genetic immune system of this donor to the patient in the hope that the new immune system he gets from a healthy donor will better control residual neuroblastoma cells after allogeneic transplantation. And allogeneic transplantation has been done already 20 years ago. As you can see here, there was a trial, but at that time allogeneic transplantation was still associated with a number of problems, which is shown here by a study from Kate Mathey, also from, published in JCO. And you see they compared this with autologous transplant, and the outcome was not very different, but this is a very important figure. The progression-free survival was lower in allogeneic transplant. That means the allogeneic transplant had some control probably over the neuroblastoma cells. So this patient had maybe a better immune system, but unfortunately more patients were lost due to the side effects of the transplant at that time. This is what we call transplant-related mortality, the TRM, which was here 20%. 1 of 5 patients died not from neuroblastoma, but from the side effects. And with the autologous transplant, and it's not that this is zero, there is also a certain TRM associated with autologous transplant, but it's not as high as with allogeneic transplant at that time. These are old data, and from this data I think we somehow lost sight of allogeneic transplantation as a tool to treat neuroblastoma cells or other solid tumors. But in the meantime, allotransplant is a long-established standard therapy for patients, especially with leukemia or other non-malignant diseases. And the first allotransplant in children was done in 86 in our hospital, or also in 79. These were then mostly patients with leukemia, not neuroblastoma at that time, only very few. And just to show you that we have made improvements in the neuroblastoma therapy, this is a study where they looked at the outcome of patients treated at several periods from 84 to 92, 92 to 2001, and more recently 2001 with 2009, patients with leukemia, which is the most common treatment for these patients. And you see this is the TRM. In the beginning, 84 to 92, the TRM was still about 30%. 1/3 of the patients were lost due to the treatment-related mortality or transplant-related mortality, but you see more recently, and the centers have learned a lot about this method, the TRM went significantly down, as you can see here. And this is nowadays below 10% in allogeneic transplant, or it should be there with the modern approaches of transplants. And also the overall survival, of course, this has impact on the overall survival, got much better over the periods of time. So we have learned a lot on allogeneic transplants, how to improve the outcome. And this is why we think we have to reconsider this approach also for patients, especially with relapsed or completely refractory tumors. Graft versus host disease is something this is a major problem in allogeneic transplantation. I just show you some of the patients, mainly with leukemia, who have graft versus host disease. This is still maybe in the classical approach. About 20-25% might get graft versus host disease, which is caused by donor T lymphocytes. Only one cell population, the T lymphocytes, which Dr. Anderson showed you in the autologous setting, he might redirect them against the tumors. Here they are directed against the patient's healthy tissue and make these side effects. But we can safely nowadays prevent graft versus host disease in most of the patients by some in vitro stem cell mobilization. And this is why we started again to use especially haploidentical transplantation in neuroblastoma. Haploidentical transplantation means that one of the parent is the donor. So not a HLA compatible sibling donor, we just take one of the parents, we look for some certain genetic features of that parent, which I don't have time to go into detail. It's called the killer inhibitory receptor phenotype of the donor, so a genetic fixed feature, which we see that at least in leukemia, this has some positive impact on the risk of relapse of these patients. So we take, it's called haploidentical because half of your genetic information is from the mother, half is from the father. That's why it's called haploidentical, and normally it's only a half match to your children if you are a donor. If you are a parent and you donate for children, it's only a half match. And this, in a classical way, might be associated with lethal graft versus host disease because of the T lymphocytes, which you also co-transfer with a stem cell product. This is what we use, peripheral stem cells from the donors, so no bone marrow harvest. These donors get also GCSF mobilization like the children for autologous transplantation. We do it with the parents. And as you can imagine, there are a lot of T lymphocytes in these preparations, and this would cause the lethal graft versus host disease if you would do it in the same way as we do it. But we have found a way, or we are improving ways to deplete these T cells. But the major advantages of haploidentical transplantation, of course, this is clear, the donor is always around and you don't have to look for him. You can collect mobilized peripheral stem cells, that gives you much more stem cells in the graft, also other cells, which I come to, especially the NK cells, we have heard a lot of those. You can do another collection in case later there is a problem in the patient. And the engraftment can easily be followed because you have a mismatch. So your cells are different from your children's cells, and you can easily see which cell is from the donor and which cell is from the patient. So it's easily to be followed. And we have also heard already a lot of NK cells that they might play a big role. And I think especially in the haploidentical transplantation, it has been shown that NK cells play a major role, especially in reducing the risk of relapse, mainly at the moment in patients with leukemia. There are solid data showing that the NK cells have a role in controlling residual disease. And we were, of course, asking the question whether this might also be the case in neuroblastoma. And when we look for the NK cell activity of such grafts against several neuroblastoma cell lines, the higher this pillar is, the better the cytotoxicity of the NK cells, and you have seen such pictures already. So the neuroblastoma cells are quite susceptible to NK cells, at least in vitro, and might be also in vivo later on. The T cells are a major problem, so we have to remove them. And it took us about almost 20 years now of work, of development work, to come to better T cell depletion techniques where we can reliably get rid of these T cells of the graft in order to avoid graft versus host disease. This is what we do at the moment for neuroblastoma. We have just recently developed a new method which works even better than this one. We have completely abandoned the old positive selection, and with these methods you get a very good T cell depletion where you can safely transplant haploidentical stem cells, T cell depleted, to a patient. And these patients do not even get post-transplant immunosuppressive therapy. So just the T cell depletion is the only therapy to avoid this graft versus host disease, which leaves the other cells unsuppressed, especially the NK cells and other cells, to fight residual tumor cells in the graft. So that's the idea behind the haploidentical transplantation. This is how we do it. It's a relatively easy method. You just use tiny magnetic microbeads, which then recognize via antibodies these T cells, and you run them through a very strong magnet. This is as strong as a MRI magnet. And then these T cells are retained in the magnet, and the rest is coming out of this magnet, and this is your graft. And this graft contains a lot of these NK cells and other cells which you want to have in the graft, but not the T cells which would cause the side effects. All other cells you can safely infuse to patients. They do not cause graft versus host disease. It's only the T cells, not the NK cells. And this is the grafts what we transplant in these patients. And this is especially here. It's with one graft up to 200 million per kilogram body weight NK cells, which is quite high numbers. These are mobilized stem cells from the parents. So, and after we were very familiar with this method and were very trustful that it will work, then we started to use this in a series of patients with solid tumors, and this is the so-called conditioning regimen. This has two aims. One is to, of course, reduce the tumor cells in the patient, but the other is also to eradicate the patient's immune system. So otherwise the patient's immune system would reject the new cells coming in from the donor, and this is a combination we use. You might know some of the drugs, maybe not fludarabine, that's not used in neuroblastoma, that's more for immunosuppression, but I think most of the patients who underwent autologous transplant, you are maybe familiar with melphalan, which has been used a lot, and maybe also thiotepa. This is the conditioning regimen, which is very well tolerated, and then the infusion of this haploidentical T cell depleted stem cells. So we have done this in a number of patients with solid tumors, mainly most of them treated in Tübingen. This comprised neuroblastoma, but also rhabdomyosarcoma, Ewing sarcoma, which is also tumors which are very difficult to treat. This was the outcome so far in 25 patients, so it was not maybe that good, but very advanced patients, I have to say. At least we have some long-term survivors here. But the more important, it was more a safety study to see whether we can do it. And this is the good news. All of the patients safely engrafted, so we had no rejection at that in this cohort of patients. So all of the patients had a complete donor immune system and donor hematopoiesis. So the patients changed the blood type from the donor. And most important is the transplant-related mortality. And in this series of 25 patients, none of the patients was lost due to the side effects of transplant. So the treatment-related mortality was 0. Remember, I showed you before that was 20% in the old data, also showing that we have made a lot of progress in preventing transplant-related mortality. And then all of the patients, when they died from relapse or from progression of the disease. Of course, these were very advanced diseases in this or stage of diseases. This is again the TRM. Now we could make it to almost zero or to zero in this initial cohort of patients. Remember, this were the 20% which caused the bad reputation of allotransplants in neuroblastoma, which we try a little bit to maybe have it looked under new light in 2013 and not in 94. So we have to re-evaluate, I think, some of these things and rethink about them. And then we would conclude from these initial results that the transplantation itself with 25% survival does not seem to be sufficient to just control tumor cells, especially neuroblastoma cells. And then we were asking the question whether what can we do to further improve the outcome by post-transplant immunotherapy. And I think this is something we have to, and we have heard a lot in the morning, what can be done for post-transplant maintenance therapy. And you have heard of the antibody, and this is also what we are using. These antibodies are very effective with NK cells. This is the first antibody, the 14G2A, from which all the other antibodies were developed, especially the chimeric, and these were very effective against neuroblastoma cells in combination with NK cells. And also in combination with NK cells and IL-2, you have a synergistic activity. This is why some of the trials add IL-2 to the antibody treatment in order to increase the cytotoxicity of the NK cells or the antibody-mediated cytotoxicity of the NK cells versus the neuroblastoma cells. And it's very important. You don't need a lot of IL-2, and I think this is a difference to the American studies, that their IL-2 dose is quite high, causing side effects. In our settings, we use lower doses in order to prevent side effects. And also interesting, this may be the reason for the GM-CSF. When you incubate granulocytes, just normal granulocytes, not NK cells, but all which are very abundant in our blood, they get anti-tumor activity in the presence of antibodies, so they also can kill neuroblastoma cells, and that was one of the reasons to also for the, I think for the US studies, to include GM-CSF, so the IL-2 GM-CSF antibody in their frontline studies. In our German studies, we have used the CH1418 prior to the Americans, but not with IL-2 and GM-CSF because this was not available at that time. And just to show you, this was our first study with the 14G2A. This was now more than 20 years ago, published in 92. We had treated 9 patients, and out of this 6 patients who had a very progressive disease, 2 had a complete remission, and one of these patients is now a medical doctor working in our hospital where he was treated. So maybe sometimes don't give up too early, I would say. But of course, this is, we would like to see this much more often, such kinds of responses. But here we have a 20-year follow-up of this, at least 2 patients. So when these patients relapse after autologous transplantation, what can we do? This is what we try. We try another response induction with topotecan, irinotecan, or whatever. We tried the RISK protocol, which you might have heard, which is a minor intensive chemotherapy. We try to do surgical intervention if possible, and if the patient at least achieves another partial remission, the better remission, the better, we proceed to our now trial, which is composed of a MIBG treatment therapy, plus haplotransplant, plus post-transplant immunotherapy. This is how it looks like. So we start the MIBG treatment to debulk further the patient, and almost all of the patients get MIBG about 3 weeks before we start the haploidentical transplantation. So we don't wait that long as we heard in the morning. I think the Americans want to wait for up to 10 weeks until they move on to the autologous transplant. We do it a little bit faster, maybe with a lower dose of MIBG, then do the haplotransplant with the NK cells, and at day 60, if it's possible and the patient has no side effects or graft-versus-host disease, we start our infusions of the antibody for the first 3 infusions, and after with the 4 infusions we start low dose interleukin-2. Maybe in the future we will start it earlier, but we were afraid to cause some graft-versus-host disease if we do it too early. And we can do up to 9 cycles. So this whole post-transplant therapy goes about for 10 to 11 months with some delays sometimes in between the cycles. So these are the participating centers. So we are the sponsor of the study, is my university, and we have 2 centers in Austria, 1 in Germany, and of course our center. And the antibody was also at that time financed by a German parents organization who had these were parents who had this patient Niels who had a refractory neuroblastoma, and they started to do a campaign, and they helped us to raise about €500,000 to have the antibody produced at a facility in Austria for our clinical trial. So this was all a private initiative, so no company or anybody involved, just parents and the doctors. So far, and a little bit in the meantime, we have more, but the follow-up is too short. We have 29 patients in this cohort, 21 patients in the study, and 8 pilot patients, which were treated very similar as in the study. Some of the patients already reached the end of the protocol, at least the 6 cycles. 12 have responded, 4 progressed, as you can see here. 6 of the patients dropped out during the study, 2 because of the side effects that were mainly pain, and the parents were afraid of these side effects. But I also have to say, as my colleague in the morning, we have learned to cope with the side effects much better, and 4 patients progressed during the treatment. So then we stopped at least this protocol approach. This is the disease status, and you can see these were all patients with a first metastatic relapse, which has a poor prognosis, and some of the patients already had a second metastatic relapse where the prognosis gets always worse. Of course, we use standard evaluation of disease. All patients get a whole body MRI, MIBG, and of course MRD detection of bone marrow for contamination with neuroblastoma cells. This is the evaluation after 6 cycles of these 16 patients, and you can see we saw in most of the patients kind of a response during the antibody treatment. And of course, we always have to take this a little bit cautious because the follow-up is still short for neuroblastoma. I have told you, you see sometimes very late relapses in neuroblastoma. That's a very unique feature sometimes of neuroblastoma. So I think we should wait at least about 5 years to make really final conclusions on this. The side effects is what we saw also with other antibody treatments, mainly the pain, fever, CRP, some of the accommodation disturbance, and only 1 patient, so graft-versus-host disease was not a huge problem. And due to the low dose of the IL-2 we used, there were no real side effects of the IL-2. So this is different than from our American colleagues, but this is dose-dependent side effects. These are the severe adverse events in the study. So these are some post-transplant infections, what we sometimes see, reactivation, and you can see what we saw, but all of them were not associated with a lethal event, just from 1 patient who a few months after transplant had an adenovirus infection and died from it, unfortunately. But that was so far the only patient who had a complication, little complication in the whole protocol among these almost 30 patients now. This is so far the outcome of these patients, and as I told you, we have to wait a little bit longer. We have to skip. This is the overall survival, but also still too short to make any comments, only about 2 years, so we need to wait a little bit longer. And how are we continuing this? So one of the things is that we have to improve the debulking of these patients frontline before this protocol. And it's not only chemotherapy which can do this. We heard about MIBG, and although the first patient was treated with MIBG in our hospital about 25 years ago now, we're still not convinced that the MIBG is the right way to go, and it has its pros and contras. So we are looking for other things. And we have these antibodies which target all the neuroblastoma cells. There is no GD2 negative neuroblastoma cells. If you have a GD2 negative neuroblastoma cells which is not recognized by these antibodies, this is probably a wrong diagnosis. So can we use these antibodies also better, not only in terms of immunotherapy, but also other approaches to debulk tumor cells? And we are looking into radiolabeling. So we can label radioactive drugs to this antibody, like copper-64, and then we can do PET imaging or MRI to see whether we can really label or target neuroblastoma cells with these drugs, and this is possible. And we have another antibody at the moment, which we are also working on, and this were all work done by Dr. Steve Gillis, who is the father of all these antibodies of the CH1418 and the humanized 1418. His name is often missed in these approaches, but he made all these antibodies. He's a biologist in the US, in Boston, and he made also this antibody, which is called delta CH2. And this part of the antibody is responsible that this antibody activates the NK cells. This makes the ADCC, the antibody-dependent cellular cytotoxicity, which is important if you want to use it to activate NK cells, but which also causes unspecific binding in the healthy tissue, because all healthy tissue has some of these Fc receptors where the antibody unspecifically bind, which might be also a reason for some of the side effects. But such an antibody is ideal in order to use it for drug development to the tumor. And we have used this antibody, as you can see, where we radiolabel the antibody, and this delta CH2 has the highest uptake in tumor cells. So because of the low unspecific binding, it's much better than the chimeric antibody. This is a control, so you can really bring cytotoxic drugs or radioactivity in a high amount specifically to the tumor cells to kill these tumor cells, in the absence, of course, of immune cells. This is not immunotherapy now, this is more directed tumor cytotoxicity. We have done this in mice also, and it works very nice that you can get a high tumor to muscle ratio of this radioactivity, as you can see here, especially with this delta CH2 antibody. Again, that this is higher has to do with the unspecific binding, so it's not around in healthy tissue, just directly enriched in the tumor, which is very important also later in patients. And when we compare this, for example, with MIBG uptake, this is the control, this is MIBG. You see that we see about threefold more radioactivity delivered to the tumor than with the MIBG. This is why we think we have to develop this kind of antibody for this debulking, like either using iodine, which I think is not the best thing to do with iodine, because then you cannot go to your children. Some of your children might have had MIBG therapy. If you can use copper-64, you can go to them, because this has not a long-range irradiation and is more effective than iodine. So we are now developing this for this kind of approach to debulk the patients prior to transplantation, either with copper-64. There is the new zirconium-89, and we are also working on alpha emitters. You might have heard of the polonium, who they use sometimes as a poison to poison some politicians. But of course here we want to poison the neuroblastoma cells by delivering these alpha emitters, not directly polonium, but a different one, to the neuroblastoma cells, and it takes only about 1 molecule of such an alpha emitter to kill a neuroblastoma cells. So if you bring 1 molecule with the antibody to a neuroblastoma cells, you will kill it. So that's the idea behind this. And we also use it as a delivery drug for other immunoliposomes, where we can put cytostatic drugs into this to have a targeted therapy, to have high concentrations of chemotherapy at the tumor and a low concentration outside the tumor, which cause otherwise the side effects. So this is, I think, our backbone or our platform. We need better radioimmunological debulking, what we can come up with, frontline. We do this conditioning regimen, we use the new T-cell depletion approach, and then we start to do the post-transplant immunotherapy. We do at the moment anti-GD2 antibody. This is ongoing, but you heard before from Dr. Andersen about the CAR or ncca-uk CAR cells. I think this is also a very, very interesting way to go, not in the autologous setting, but in the allogeneic setting, where we use the new healthy immune system of the donor in order to control the disease of the patients. And I hope that maybe in one of the next meetings I can show you some more data, whether we made progress or not. As we heard, the regulations are tough. It's very difficult to work against them, but we have to keep on trying. Thank you.